now. So now we're recording, and this will be available for future watching and rewatching later on. And I believe those are all the announcements for now. So I want to introduce our speakers for today. We are very fortunate to have Gabby Torres with us. And Gabby is an MD candidate. She's a medical school at KU School of Medicine, class of 2025. So almost there, Gabby, right? It must be so exciting to see that great day next spring coming up. We're very excited to have you until then. Gabby is going to specialize in otolaryngology, which is the study of ears, noses, and throats. And today she's going to talk with us about what that might look like and how it will have an impact on our cognitive change. And I know everybody on the webinar is quite interested in that. So we're excited to hear from Gabby. While Gabby talks, I'm going to put a link in the chat to a study we have at the ADRC. It's called the Aroma Study, and it is some smell testing that looks at our sense of smell and its impact on cognitive performance and cognitive impairment and Alzheimer's disease. Folks who are eligible are between ages 50 and 80, who have anything from normal cognition to a diagnosis of Alzheimer's disease. And the study includes a testing a sense of smell, a brief physical activity test, a blood draw, and an optional MRI. And it will include 4 visits over 3 years. So if you want to sniff that out, come on, you knew I was going to say it. I will put a link in the chat, and you can visit that link to get more information about the study. I'll also put our research phone number in the chat. You can call and talk to any of the recruitment team, and they can let you know about that or any other studies. Thank you to my wonderful colleague Tina for putting that chat or that link in the chat. So with that, Gabby, thank you so much for being here. I'm going to turn it over to you.
All right, thank you, Kelly. And like Kelly said, my name is Gabby. I'm a 4th-year medical student. Let me get my screen shared. Perfect. Okay. And so, like she said, I'm interested in ENT, and ears, nose, and throat is a very, very broad field. And so today I chose to focus on the hearing aspects. So the ears, those are my favorite. And I'm going to be talking about hearing loss and cognitive function. And I'm just going to do a very, very general overview first on hearing. Why are we concerned about hearing loss? What exactly even is hearing loss? And then kind of more into when to get everything checked out and what we know about cognitive function in here. Okay, so first, one of the biggest things we ask ourselves in medicine whenever there's a problem is, how many people is it affecting? How big of a problem is it? And so this was one of the stats that I thought was really interesting. So hearing and age. So by the time people are between the ages of 44 and 54, about 11% will have some degree of hearing loss. By the time people are between 55 and 64, 25%. So a quarter of people will have some degree of hearing loss. By the time people are 65 to 84, 43% will have some degree of hearing loss. And then I believe 85 to 94, 50%. So half of them will have some degree of hearing loss. And hearing loss is a spectrum from mild all the way to profound. But there's a lot of people who are affected by hearing loss. So this is something that as ENTs and just even like many different types of physicians, something that they're worried about. Okay, and so just very quickly about the ear, because a lot of times people don't really know much about what the ear is or what it does other than hearing or how it functions. So first we have the outer ear. That's like the cartilaginous, like funky little thing that sticks out on the side of our head. And what it essentially does is works as a funnel. There's all these sound waves throughout the air, and it kind of works to funnel everything in. And then there's the middle ear. A lot of people have heard of their eardrum. So that's the beginning of the middle ear, and it acts like a gong. So think of all the sound waves hitting it, and then it's going to start vibrating. And that's going to trigger the middle ear, which is made up of 3 bones. And those bones, in a very simplified way, they also vibrate, but then there's more fine tuning till it gets to the stapes, which is actually the smallest bone in the body, which is a fun fact. And so the stapes has gotten the vibrations, and they're more fine tuned. And then that's going to be touching the inner ear through the oval window and then through the cochlea. And the cochlea is this crazy looking little 3D structure in our head. And There's other portions that have to do more with like sensing velocity and positioning. If people have ever had problems with vertigo, that's also in tune. But the bottom part that looks like a snail shell, that's what we are worried about with hearing. And so inside the cochlea, there's fluid called endolymph. And so remember, the stapes is giving these little vibrations and it's moving that endolymph. And lining the cochlea are all these tiny little hairs. And those hairs are called inner hair cells, but they're not really hair. They're part of like our nervous system. They're neuronal in origin. And so those little hairs are going to bend, and that's going to send a signal down into more nerves and to go through the auditory nerve all the way into our brain to the auditory cortex, where our brain is going to actually perceive what is it exactly that we're hearing. So just in a very, very simplified nutshell, that is how our ears hear. And as you can see, there's so many different parts of the ear that and throughout the ear that need to work in order for us to perceive hearing correctly. So then just talking a little bit about hearing loss. So we know how we explained a little bit about how we are hearing. Next, about when we lose that ability. So there's actually two types. There's conductive and sensorineural. So conductive is more to do with up until the point of the inner ear. So if someone has like a big ball of wax that is just kind of obstructing, it's kind of like a roadblock. Those waves aren't able to get in. Same with the middle ear. If those bones, if they become stenosed, so they get really stiff and they aren't able to vibrate how they're supposed to, that can also lead to a conductive. So it's like a hard stop. The waves aren't even able to get to the nerves before that signal stops. Then sensorineural, where there's an actual problem with either the inner hair cells, the auditory nerve, or the brain. And so then this leads us to a word, presbycusis. It's a very, very fancy word, and all it means is age-related hearing loss. So we know that as people age, their hearing just isn't as quite as sharp, and it's actually sensorineural because they start to kind of get a degeneration of those inner hair cells, and specifically, first, it's at higher frequency. So think of higher pitch sounds is what goes first with age. And then other related conditions to have to do with hearing loss. I also want to touch on tinnitus. So that's kind of like a ringing in the ears that's constantly there. Vertigo, like that spinning sensation, disequilibrium, which is just feeling off balance. So hearing loss and all of these conditions can be very closely related. And for tinnitus, it's very bothersome. Vertigo and disequilibrium, it can lead to falls. And this is obviously something that we also do not want in people who are advanced age. And we also think of how does hearing loss affect a person? So it can actually affect their quality of life. It can lead to isolation. A lot of times people become embarrassed or they become really frustrated that they're not able to hear properly. They don't want to talk with people anymore. And this can contribute or worsen anxiety and depression. And then also just some things that can lead to hearing loss. So a lot of times, most of the bulk of the damage is actually done when we're young. And so one of the biggest things is actually occupational exposure. So people who are around heavy machinery, like construction workers or people who have served in the military, ototoxins, that's certain chemotherapy agents. People who smoke tend to have more hearing loss, and then just people who have predisposing genetics. So it is true that if you know someone who's younger in your life who constantly likes to blast loud music in their ears, it can actually lead to worsening in hearing loss later in age. And so now to the big topic of our cognitive impairment and hearing. So first, we always want to make sure we are differentiating the two. So they actually can start to kind of mimic each other. It's hard to conceptualize, but if we think of an example of, let's say you have an older family member who is losing their hearing, and you have a family member who's, says you have an appointment tomorrow at 2 p.m., but their back is turned. And so the person speaking didn't realize that they weren't heard. And then the person didn't realize they were being spoken to. So then later on, when that family member says, your appointment tomorrow at 2, they become concerned because their family member says, I don't remember you saying that. You never said that. And then the older family member might become concerned, am I not remembering things? Like what's happening? So it's very important to differentiate the two because they can actually start to mimic each other. But then what does our data say? Does hearing loss cause cognitive impairment? How are they correlated? Does it make it worse? And so we don't have anything that's clear-cut causation, but we do have lots of data. And of the many, many articles, I just decided to choose one. It is called Age-Related Hearing Loss and Cognitive Decline, the Potential Mechanisms Linking the Two. And so this is a very good paper that goes in depth into all the theories and the mechanisms. But in the very grand scheme result of it is that there's a risk factor for cognitive decline if you have hearing loss. So that's to say, if we had one group of individuals of around the same age with no hearing loss, then we had another group of individuals who had some extent of hearing loss. The group of people who had hearing loss would have a higher risk of cognitive impairment. So just the same way that, dieting and exercise doesn't 100% prevent people to develop things like diabetes or hypertension, it's the same way that having a risk factor doesn't completely 100% mean that that person is going to develop said condition, but it does increase their risk. And of cognitive decline, the risk factors, this is only the few ones that can be modified or helped, because the number one risk factor is age. We can't change our age. And so there's lots of risk factors that go into it, like genetics or gender. And so of all those risk factors that one person may have, if we can reduce or eliminate one, then that is still something we want to do. And that's not to say that they won't still develop it, but if we can help the risk, then that is something that we would want to do. So then just something of when to get evaluated. So we always just tell people that if they themselves or their family notices changes in their hearing, it's always good to start mentioning it to a doctor. And so some of these signs might be that it's harder to hear in a social environment. It's called the cocktail party effect. So this is where if you're talking one-on-one with a person, you may be able to hear them just fine. It's not difficult. But once you get yourself in a setting where there's background noise, there's multiple conversations going on, it might become very difficult to be able to hear and understand. Also, just things like needing to increase the TV volume, and then difficulty with female voices. Since females tend to have higher pitched voices, they are sometimes harder to hear than males who have very deep voices. And then also, any sort of other ear-related problems like tinnitus, remember that's that ringing in the ears. There's actually a theory that if we can no longer hear from like an outside perspective, our brain doesn't like the fact that we no longer can hear. And so it will start to fill in that void with the ringing. And so tinnitus is not actually hearing a sound. It's actually an absence of sound that our brain creates a perception of. And so anyone who starts to have really bad tinnitus should definitely be checked for their hearing. And then people who have vertigo or balance problems, there's certain conditions where hearing loss and the vertigo or balance problems kind of go hand in hand. So there's kind of some of the signs to get evaluated. And then also, where would you go and what could be done if you did think you had hearing loss? So the number one best place to start is always with primary care provider, just mentioning, and the first thing they're going to do is take a history of asking, how do you think your hearing has changed? What are some of the signs that you believe you've seen? And they can actually do a very quick exam just by like using certain instruments or having people close their eyes and like putting certain sounds to see if they can hear them. But then the true objective way is through something called an audiogram, which is done by an audiologist, which can be referred. And so that is when you actually get like put in a soundproof room with headphones put over, and the audiogram actually gives a result of being able to tell whether it's conductive or sensorineural hearing loss in origin, and to what extent, if it's mild, moderate, severe, or profound. And so one of the biggest things that can be done is hearing aids. And hearing aids have become a lot more accessible. I believe pretty recently they were able to become over the counter, but a lot of people still get them through doctor's offices because they can be very helpful and be able to tune them and get the correct type. But yeah, so hearing aids are something that work as to amplify sound, and so it helps people hear better. But then where do ENT doctors come with hearing? So there are certain patients where their hearing loss becomes so severe that hearing aids just aren't able to be helpful anymore, as well as people who have tinnitus, balance dysfunction, or vertigo that after an initial workup by a different doctor just it's still a little muddy. So it's always good to get referred to an ENT if that is the people who fit into that bucket. And then for hearing loss specifically, something that ENTs can do is actually a surgery. It's called a cochlear implant. And so it's a device that surgically is inserted. It's under the skin, and it acts as a processor to directly stimulate the auditory nerve. And so there's like a big metal part that goes underneath the skin behind the ear, and then the bone behind the ear is actually drilled because there's a little probe that actually gets snaked into the cochlea. So it acts as the processor itself. And this is really good for people with very profound hearing loss that without hearing aids, they're essentially deaf, because it's not good for people with just mild, because you actually have to relearn how to hear, because it's a different avenue of getting your auditory information now. And so I just wanted to do a very quick recap. Hearing loss affects many individuals as age increases. And as that happens, it can lead to, quality of life problems. It increases the risk for cognitive impairment. So it will not single-handedly cause, but it can increase the risk. It is one of the few modifiable risk factors we have for dementia. So if we can do something about it, we should. If you believe you're starting to have hearing loss problems, start with a PCP and get the ball rolling there. And then people with hearing loss can use hearing aids, or people who are refractory to hearing loss can get surgical correction with cochlear implantation. And then just a few of the resources I used for this. And thank you so much for listening.
Thank you, Gabby. Thank you, future Dr. Torres, for giving us such great insight and information on hearing loss and changes in cognition. I'll point you to a question in the chat that maybe you can give us some guidance on about frontotemporal disorder. So I'll give you a moment, Gabby, if you don't mind, to take a look at that. And to the person who asked about Medicare coverage, I put a link to Medicare's information about what it does and does not cover in terms of hearing exams and audiograms. And I've been sort of thinking about this for a while, and this confirms it. I will do an upcoming weekly webinar on Medicare and dementia diagnoses, so stay tuned for that. And then maybe, Gabby, I can turn it back over to you for that question.
Yes. So there actually is a way to determine whether dizziness is a brain problem or an ear problem. And so first there's actually like this whole thing where you get put in a fancy chair and it does a bunch of testing. And so if those results are abnormal or normal, it can lead to more pointing, is this more ear or is this more brain? And also doing brain imaging as well can also be more definitive, but definitely something to talk about a neurologist or an ENT about. In regards to if there's a specific decibel level, not that I'm aware of. That is a good question. That'd probably be a very good study to have done. Okay. Okay, I think that's the only question I see.
Thanks, Gabby. We'll add that up to our list of things for possible investigation about the decibels. Other questions from the group about hearing. Oh, it looks like there's a new chat here. Oh, you're welcome. You're welcome, Gabby. Thank you. Anything else you were wanting to hear about or ask our expert about in terms of ears, noses, and throats? When do you think the aroma test will be an early intervention test in an ENT's office? That's a great question. I don't know if we have anybody from the aroma team on our webinar today. If we do, you all please feel free to speak up. If not, I will save this question and ask the team and get back to you with an answer. Maybe I can send somebody a quick message right now. So I don't know for right now. Tina, do you have any insight onto that? No.
No, I know they're still doing research on it. And of course, the research study is going on for a couple of years, actually. And so once they're done with the research study, then they'll gather all of their data and they'll analyze it and then they'll submit it for publication. So probably could be a little while just because the study isn't done yet.
Okay, sounds like that's a good reason to stay tuned to the weekly webinar and the My Alliance, because you'll hear it here first from us when we know what the outcome of these and all of our studies are. So hang in there, and we'll certainly have to ask Gabby to come back and give us some updates if and when she has time in her future career as a physician. Okay, looks like we've got I've got a question that came directly to me, Gabby. I'll read it to you. Can you share some other basic ways to prevent hearing loss over one's lifetime?
Really it's just protecting. So making sure that, especially nowadays, now everyone has AirPods, some sort of headphones, making sure that you are not using them for extended period of time, especially at loud volumes. So that would be the number one way. And then they actually make like over the ear head protection. So that's something if you're very worried about your hearing, you could wear to like certain sporting events or concerts. I actually think they make like really discreet, small in the ear ones now that kind of like dampen the noise. And so just if you're around that, or if you're in an occupation that is around really heavy machinery, really being consistent with your ear or over the ear protection. So it's just, there's nothing other than just protecting our ears from loud volume that I can really think of.
Cool. I know there's a few concerts coming up in Kansas City. I'm actually going to two concerts this weekend, Friday evening and Sunday evening. So I will have to keep that in mind as I attend. One of them is Boys to Men at Starlight. I feel like that'll be nice and calm and not too rocking, maybe a little bit of rocking, but this is a timely conversation. So thank you for that. And Gabby, we have another question in the chat about how COVID impacted that study. I don't know if you have any thoughts about COVID and hearing loss. And then, we've got a couple more. So great, everybody. Thanks for your questions. Pat wants to know about eustachian tubes, and Lloyd wants to know about wax removal. So Gabby, if you have some thoughts about those three new questions, that would be great.
Yes. So is the COVID one about the aromatherapy?
I think it probably is.
Yes.
Related to this study. So I'll have to add that to I've already started a list of things to find out related to the aroma study. So to the person who asked that question, I'm sure I have your email address, and I will talk with the team and get an answer for you about COVID. So maybe we can go to Pat's question about eustachian tubes.
Yes. So in regards to eustachian tube dysfunction itself, by itself, I'm not sure if that would cause hearing loss, but there actually is chronic ear infections actually can lead to hearing loss. That hearing loss actually can sometimes be temporary, especially in children. We see a lot of kids who get chronic ear infections, they almost develop this like effusion or like buildup of volume behind their eardrum that kind of dampens that noise. And we actually see in children, if they're left with that long enough, their language development starts to become stunted because they're not able to hear. So that's why so many kids get ear tubes, because easy surgery and we're able to be on track for their development. But definitely, is there a way to get rid of it for good? So in regards to chronic ear infections, the number one mainstay treatment that an ENT would do, other than if antibiotics have already been exhausted, would be tubes. So in kids, it's a very easy surgery. The anesthesia is much longer than the surgery. Adults can actually get tubes put in outpatient. It's just because kids are very squirmy. And so adults can actually get tubes put in an outpatient setting. And then in regards to the eustachian tube dysfunction, I'm not exactly sure about the cause of hearing loss, but there are some people who get eustachian tube dilations. And it's a little mixed in the otology community, whether we think that that is actually like curative or helpful, but for some patients, it does work. And then for wax removal, Debrox or Hydrogen, I'm assuming Debrox is like the little kit you get at a grocery, at like just like Walgreens. The kit works perfectly fine. So yeah, they make like wax removal kits. So whatever is in that is good. You can also use like mineral oil is what some people use. Then making sure you're not, if you're using Q-tips, making sure you're only going on the outer portion of the ear, because if you go in, you can actually start pushing it in further. So making sure Q-tips only on the outside, and then yeah, just any over-the-counter earwax removal kit works pretty well. And yes, Mandy talked about the reusable earplugs. I think those are the ones that I was thinking of. They reduce the sound, but they're not muffling it.
Cool.
Um, mm,
While Gabby's looking at the next question, I'm gonna say to Lloyd, probably you should never remove your ear. I couldn't resist, but I think if you're asking about removing earwax, I'll let Gabby answer that one.
we can-
Thank you.
You're welcome.
Um, yeah, so in response to Michelle's question about Eustachian tube dysfunction, it is something that is very frustrating to have and to treat because, like I said, there's those dilations, but it's kind of mixed results on whether they help people or not. And that's very interesting that you're getting a lot as an adult. That definitely, yeah. And so the tubes do fall out. And so that has more to do with the chronic infections, not necessarily the eustachian tube itself. So from what the minimal experience that I know so far about the ears is that really the only procedure that they would be able to do is that dilation. And how often to remove earwax. So a lot of people don't actually need to routinely do it. It's more, some people are just more waxy than others. So it's just personal preference. If you're starting to notice that you're having a lot more wax, then you can do the kit every now and then. But it's definitely something that I don't think needs to be done on a regular basis. It's more if you're noticing a lot of buildup. What about sinus surgery for ear problems? So, the sinuses are definitely closely related to the ears. I myself have had to have sinus surgery. So yeah, whenever you're getting constant sinus infections and then it's like causing also infections of the middle ears, it's just kind of all these tubes are interrelated. I definitely think having chronic sinusitis is not fun. And so that's something to get worked up as well. Because ever since I got my sinus surgery, I have not had a sinus infection or ear infection since. So definitely helps a lot. And yeah, but yes, it's very frustrating and everything just gets congested altogether.
Wow, what a wealth of information you are, Gabby. Thank you so much. You reminded me that I had PE tube placed in my ears when I was about 8. And I don't remember having any recent ear infections, so I think that must have been a success. Just as our webinar today has been a success. Thank you so much. Everybody has asked some really great questions. I'm glad we have this recorded so we can refer back to it, and we'll have it on YouTube pretty soon. Next week, we will have Dr. Heather Wilkins back with us. And she's going to be talking about a new study that she's working on. Remember, she's our biomarker expert. And her new study is the ADDF study. We'll have more information in the newsletter about that on Monday, and she'll be talking about that and biomarkers next Thursday. So stay tuned for that. Gabby, again, thank you so much. I think our ears, nose, and throats are in really good hands with you, and appreciate your sharing your time on the webinar today. For the questions that we couldn't quite answer today, I will see what I can find out and let you all know. And with that, unless anybody has any other questions, we'll wrap up for today. Hope your August continues to be wonderful, and we'll see you next week. Oh, you're welcome, everyone.
Thank you for having me.
Oh, our pleasure. All right, everyone. Bye-bye.
Bye.